Mhm.
Okay, great. Okay, so guys, let me start by saying that this, feel free to chime in and add discussion or thoughts to the chat, or just like raise the hand, if you want to comment or unmute yourself. Because I really don't consider myself a super duper expert on this. I'm really just, the messenger. I first want to start off by saying really credit goes to Isabel, who couldn't join us today, for putting this kind of talk together. And we had hoped that maybe she could come and do it with me. We're really just reviewing the latest updates and guidelines from the APA equity, diversity, and inclusion inclusive language guide. So some of this stuff, depending on how much, if at all, it's covered, hopefully in your coursework. Some of it might seem really familiar, but for some people maybe who aren't getting it, it may not. So, and certainly there was a lot for me to learn as well. I said we were putting this together. There are some things that I know that I'm guilty of, and so there's so much to um, cover in all of this that in this language guide. And I will send you guys in the chat. Actually, let me do that now. Well, I'll do it at the end. The link for the PDF, so that you can take a closer look, because there are a lot more like examples and explanations, more than can be certainly covered in one talk. But anyways, with that in mind, I'm going to kind of go through some of the key points from the inclusive language guide. And if you, like I said, have thoughts or comments or experiences that are reflective of some of these, I would really welcome the input and participation. Like I said, I'm by no means an expert on this. I am, have been a member of CFI's DEI initiative and committee. And I'm kind of here as like the imparter of this, language guide that was really developed by professionals more seasoned than myself. And the people who do the research in this area. So I'm really just the deliverer of information. So I welcome thoughts and input. And if you guys want to discuss any things that have come up in your own clinical work, I would really welcome it. And I'm going to kind of cover the key points and send you this so that you can um, look at the PDF that really has it in far more detail, more closely, and have it on hand for when you do your writing, research, clinical write-ups, anything like that. So hold on one sec. I'm just going to make this full screen. And I really kind of want to reiterate that credit really goes to Isabel, who put this together on my behalf. Like I said, I'm just here as sort of a representative figurehead to kind of go through all of this with you. But she really put a lot of time into this. So is bummed she couldn't join today. But anyways, all right. So DEI at CFI and inclusive language guidelines. Has anyone, by the way, read through the PDF or been um, um, uh, familiarized themselves, has had covered this in your coursework? I'm seeing, sorry, I'm going through the pictures, seeing some head nods. Okay, so please feel free, no, some head shakes. Okay, so good. So some of this will be new for you guys. Some of this might be overview, and feel free, like I said, to chime in. Okay. So, all right. Okay. All right. How do I? There we go. So the overview, we're going to be defining DEI at CFI and just reviewing the APA inclusive language guidelines, which covers kind of two main areas, inclusive language in writing and avoiding microaggressions in conversation. Sorry, and I have like my notes here. So if I look like I'm looking off camera, that's why I'm doing it at the same time. So diversity, the who. So at CFI, we recognize and accept that people from diverse, often marginalized communities along a large spectrum of client diversifying characteristics, racial, physical, gender, cultural, socioeconomic, will need mental health care at times in their lives. And in order for us to provide the most effective treatments possible to all of our clients, regardless of their backgrounds or circumstances, we aim to incorporate diversity in all aspects CFI life and care, from our clinical staff and services to our research and education, our partnerships. And it's obviously, I don't want to speak on Adam's behalf, but always a work in progress, right? Um, the what? Equity. As a mission-driven organization, we aim to build awareness of and be responsive to the unique mental health needs of those from underserved and underrepresented populations. Equity at CFI is a state of being or mindset for how we conduct ourselves. While we acknowledge the tension between equitable and equal, that is the potential disequal distribution of clinical and financial resources toward equitable treatment, we nonetheless seek to elevate all our clients to the same level and quality of mental health and healthcare. And that's really the mission of not just CFI, but obviously Adams Weissman Children's Foundation. Inclusion, the how, which is WCF. To attract a diverse and largely underserved clientele, CFI aims to create a warm and open and welcoming environment to provide affordable, timely, and effective mental health treatment, hence our focus on evidence-based interventions. Our highly qualified clinicians follow an ethical code and conduct due to diligence in offering well-informed, culturally sensitive therapeutic services for anyone in need. To do this, we will recognize and help minimize potential barriers to treatment, in part by addressing the client's experience of discrimination, bullying, labeling, social dynamics such as, clients' ability to initiate and keep friendships as compared to their peers. So like I said, this is really divided into two kind of main parts. The first part being inclusive language and writing, and the second being avoiding microaggressions in conversation. Inclusive language and writing, avoiding using language that may perpetuate stereotypes or marginalize certain groups. Therapists should strive to communicate in a way that fosters trust and respect. And in avoiding microaggressions, we want to use inclusive language guidelines to create a welcoming environment for all clients, regardless of background or identity. Therapists should be mindful, as we all know, that mindful of the impact words can have on individuals. And in preparing for this talk, I really had to also be became aware of some of the things that I still say and do without awareness. So it certainly helped it's always good to do a refresher on these, even if you haven't looked at these guidelines, if you've had exposure to them in a while, because things are ever evolving. And, I certainly became aware of some things for myself that were not as familiar to me, which was helpful to know. So inclusive languaging writing. So we're going to kind of cover three main areas, which is the general terms related to equity and power. We're going to discuss person first and identity first language, and then identity related terms. And by utilizing inclusive language, therapists can create obviously a safe and welcoming environment for all clients, promoting trust and understanding in the therapeutic relationship. All right. General terms related to equity and power is where we'll start. Sorry, guys. If anyone, by the way, is trying to signal to me, just please use, because I'm minimizing the window so I can see the slides. Just put something in the chat, because I'm going to kind of close it so it doesn't block the slides for me. So when we think about this, there are three areas or key points, right? So cultural humility, competence, and responsiveness. So cultural humility is a lifelong commitment to learning, self-reflection, challenging our own biases about diverse cultures that are different from yours, acknowledging that identity is complex and that each person's experiences are unique, diverse, and valid, and seeking to redress power imbalances and to develop mutually beneficial and equitable partnerships with communities on behalf of individuals and defined populations. Cultural competence, the ability to collaborate effectively with people from different cultures, this can improve experience and outcomes of care for different people. Does not refer to a process that ends simply because the clinician is deemed competent or because the professional is from the culture in question. Incorporates a cultural humility and is considered a lifelong process of reflection and commitment. One can commit to the process of lifelong reflection to be aware, responsive, and accountable to the communities one is serving or working with. And as I mentioned, this is an ongoing thing, and I certainly even learned a lot or reminded myself of a lot as I was preparing for this. Cultural responsiveness, understanding and responding appropriately to the different aspects of culture and diversity that an individual brings to interactions. Requires valuing diversity, desiring to increase knowledge about other cultures, and striving to create spaces where diversity is integrated. So the first term, there are, and if you go to the inclusive language guidelines from APA, there are a lot of terms there. So we decided to kind of pluck out a handful just to kind of cover some of the terms for you guys, but there's a lot more that certainly we didn't cover. And so I encourage you guys to take a look and go through it. But we'll just cover a select few today. So first one being is population health. So this is the examination of health risks of specific groups of people, and it involves a multi-tiered approach that includes universal provision of preventative tools and health promotion for all people, families, and communities, monitoring, anticipatory guidance, and early intervention for those with risk factors for physical, mental health, and substance-related conditions, psychosocial mental health and or substance use care for those experiencing illness or worsening physical health and mental distress. Equity, we hear this phrase a lot these days, this term a lot, and just to make sure everybody understands what it means, it's the ongoing process of assessing needs, correcting historical inequalities, and creating conditions for optimal outcomes by members of all social identity groups. Means providing resources according to the need to help diverse populations achieve their highest state of overall health and functioning, and breaking down barriers to achievement of fair outcomes. And along those lines, then, health equity means to ensure that all have the opportunity to be as healthy as possible by removing poverty, discrimination, related obstacles, including powerlessness and lack of access to good jobs with fair pay, quality education, health and housing, safe environments, and healthcare. I have a friend whose husband is. It was so interesting to work with him once or to speak with him because his whole job in sort of area in urban planning and development, and his background was in design, architecture, and again, urban planning, was really around designing systems citywide to increase access to reasonable healthcare for people from different areas. And we think about how much goes into that from can you see the population health side again? Sure. And I'm happy to share these too. Hold on, sorry, I have to go. I think I can go back that way. There we go, population health. And you know what I'll do is I'll also put the PDF in the chat at the end as well. And so, we think about all these, there's obviously us at the individual clinician level, but so many system approaches that can facilitate equitable access to healthcare. And it was really interesting to have a conversation with someone in a totally different field about what role that they play around things like transportation, services, building, access to buildings, like I said, urban planning, design, and that is what a lot of his role is in another city. Does anyone mind if I move on? Is that okay, Margaret? Okay. And so, for example, along health equity, for example, individuals with disabilities encounter multiple obstacles to equitably access healthcare, including lack of government-funded and or insurance-covered aids, transportation and medical equipment, disproportionate level of poverty associated with having a disability, and the difficulty of obtaining and or maintaining gainful employment, which further creates barriers to healthcare. Good example of this that I, encountered a lot in my former life. For those who work with me, know a little bit about my professional background, was that I was at NYU. I was at the hospital for many years, and obviously as a neuropsychologist, my specialty was working with neurodivergent populations, and a lot of my patients had physical and mobility disabilities that necessitated their reliance on things like Access-a-Ride and public transportation. And so a lot of these services, even though while they're available, so for example, if one of my patients had an appointment at like 1 o'clock in the afternoon, their ride, in order to ensure that they made it on time, would sometimes come at 8 o'clock in the morning. And then that ride could have been an hour late or sometimes even early. And so if they missed that, they would be stuck. Or then, gosh forbid, there's weather or there's traffic, they could end up showing up somehow still an hour late, even though they were picked up that early. And so if you think about all the factors that go into that, is we're giving the transportation, but it doesn't always make it very easy. For example, if some of these people are working and need to, it's hard to maintain employment if you have to basically take a whole day off. Yes, many barriers of access, whole day off for one, doctor's appointment. Because of the nature of how you get transported to that. And you have to sort of prepare for the fact that you're going to spend longer trying to get to and from the appointment than you are actually at the appointment. And that was something that we often came across. And certainly, like, as soon as it was raining, we kind of always knew that all of our appointments were going to be late that day when I was outpatient and physical rehab. For people that use wheelchairs or other other things to aid in their mobility, that if they were relying on even public transportation, it was going to take them a while to get there. And that was just sort of a known thing, or the appointment would end up being canceled or so forth. And so I think about that one a lot. Another term, historical trauma, multi-generational trauma experienced by a specific cultural, racial, or ethnic group. It's related to major events that oppressed a specific group of people, such as slavery, the Holocaust, forced migration, violent colonization of indigenous populations, including Native Americans, Alaska Natives, Native Hawaiians. And the potential downstream effects of historical trauma include negative physical and mental health outcomes, worsening of acute issues like domestic violence, substance abuse, and high rates of suicide. In addition, it involves the additional challenge of a damaged cultural identity. Who am I, and where do I fit in this? And what is my cultural identity? And this sort of leads to the next one, which is intergenerational trauma. Actually, on the last one, I also kind of wanted to just really quickly go back to the historical trauma one that's relevant, since a lot of us work with kids, is that in historical drama, also keeping in mind for us that parents and caregivers and caretakers' experience of historical trauma can disrupt typical parenting skills, right? And contribute to behavioral problems in children. And so that's something that we want to think about too, as we think about many of us that work obviously with children and parents and families, that this is that this affects everybody. And that leads me into kind of the next one, which is intergenerational trauma. The transmission of trauma or its legacy in the form of a psychological consequence of an injury, attack, or poverty from the generation experiencing the trauma to subsequent generations. And transference of this effect is believed to be done via epigenetic inheritance, meaning that it's the study, it's how our behaviors and environment can cause changes that affect the way your genes work. So transference of this effect is believed to be done by epigenetic inheritance, meaning that a generation's phenotypical responses to environmental challenges and trauma changes the expression of certain genes, and that new gene expression may be transmitted to the offspring via epigenetic inheritance, even when the young generations do not experience the challenges themselves. Research suggests that molecular representation of intergenerational experiences may validate the experiences of children who feel the effects of trauma exposure from previous generations. Positionality. So one's social position or a place in a given society in relation to race, ethnicity, and other statuses, age, gender identity and expression, religion, national origin, immigration status, language, disability, sexual orientation, socioeconomic status within systems of power and oppression. Positionality refers to individual identities and the intersection of those identities and statuses with systems of privilege and oppression. It shapes a person's psychological experiences, worldview, perceptions others have of them, social relationships, and access to resources. Positionality, therefore, means actively understanding and negotiating the systemic processes and hierarchy of power and the ways that statuses affect relationship because of power dynamics related to a privilege and oppression. Which also then goes to intersectionality. So the complex cumulative way in which the effects of multiple forms of discrimination combine, overlap, or intersect, especially in the experiences of marginalized individuals or groups to produce and sustain complex inequities. Categories like gender, race, and class are best understood as overlapping and mutually constitutive rather than isolated and distinct. Initial work on this topic has focused on Black women's experiences with racism and sexism. Structural competency. So the ability to discern how issues defined clinically as symptoms, attitudes, or diseases, for example, depression, hypertension, obesity, etc., are influenced by upstream decisions, for example, access to education, healthcare, food delivery systems, zoning laws, urban and rural infrastructures, as you heard me mention earlier, or even the very definitions of illness and health, which is something we're talking a lot now. It comes up later when we talk about labels and around body image and size, which I'll talk about later. Downstream efforts may be conceptualized at the individual or family level of intervention, whereas upstream efforts focus on more of the distribution of power, wealth, opportunities, and decision-making at the societal level. Minority, I know like people know what this means, but we wanted to cover this one because there are a lot of new kind of thoughts on how to phrase things. A minority group is a population subgroup, ethnic, racial, religious, or other group with differential power than those who hold the majority power in a population. The relevance of this term with regard to race and ethnicity is outdated, given the changing demographics of the US population. Thus, we refrain from using the term minority. Instead, the guidelines now are to use the specific name of the group or groups to which you refer, or use broader terms such as people of color or communities of color, as opposed to being ethnic and racial minorities. Or you may describe the population as being minoritized. You may also consider using the phrase individuals from underrepresented groups, historically marginalized communities, or individuals with marginalized identities. Still permissible to refer to the sexual and gender populations as minority populations. And so before I kind of go into the next section, I want to just kind of highlight that this in the PDF, this really goes through a lot of, again, these were some ones that we covered, just that we thought were more overarching terms that we've used a lot, but there's a lot around, for instance, the terms cultural competence, cultural humility, decolonization, discrimination, even the word diverse, global citizenship. So all of these are in human rights, implicit bias. All of these are in the PDF, and obviously we wish we had time to cover them all, but want to kind of give you a sense that there are a lot more to this. Any thoughts or things that people want to chime in so far?
I had a question, Dr. Saigal, about the person first and identity first language, because when I was getting my master's, it looks like there was a shift or a trend, because we were like, it was ingrained. You do person first, individual with a disability. And now I'm hearing more. And then when I hear people describing with the, I'm like, oh no, you can't do that. And then like I was at I think it was a recent didactic, and they were saying that it was okay, and actually it was preference to ask the individuals. I thought was really interesting. What do you prefer? So I thought, hey, that's the way that you can just, be at the best of both worlds. If if you ask how somebody wants to be called, it's always better than to not, right? So
correct, exactly. That is literally, you're going to see the next slide. So
I just thought it was interesting because I had a totally different education.
This one, I really, as I reread, and I mean, this is the I think the second or third edition of the inclusive language guide. And honestly, like I said, it's, for me who, wasn't in school that recently, it's always good to, it's a good, this is why we teach. This is why people like me teach. Also because I think you're learning at the same time that you're teaching, and forces you to stay up to date on literature and things like that. So that's something I struggled with, Margaret, as well, certainly in my training, and trying to, I know that some of the things that come out of my mouth are very automatic and sometimes outdated. And so I really have to be mindful. And I think when it comes to person first and identity first, they say using the preferred approach to language when discussing people with disabilities, whether it's person first or identity first, or a mixture of both, ultimately treats people with respect and helps reduce bias and practice research, educational settings. And I think, as you just said, this was first discussed in the context of issues related to people with disabilities, but now been brought in to include other groups. So authors are writing about identity are encouraged to use terms that both honor and explain person first and identity first perspectives, but keep in mind that an individual's preference supersedes matters of style and general rules. So if you're not sure, takeaway, just ask. So what's the difference? Person first, for those less familiar, is, and sorry, again, thank you, please, for chiming in. Thank you for doing that, Margaret, because I'm going to, just so I can see my slides and everything that I'm looking at, I'm just going to minimize again, so I can't see any of you, but person first language places emphasis on the person rather than the disability. An example would be, instead of homeless people, saying people without housing. And identity first language, the disability becomes the focus that allows the individual to claim the disability and choose their identity rather than permitting others to name it or select terms with negative implications. It's often used as a reclamation of terms previously used with negative implications. So for example, in terms of person first for identity first language, terms to avoid, for example, some of the guidelines, and there's a lot of examples in the text that, again, we won't go through them all, but just to give you some suggestive alternatives, instead of saying wheelchair bound, person who uses a wheelchair, confined to a wheelchair user, mentally ill, person living with mental illness. Obviously, terms like crazy, insane, mental defect. Again, person living with a mental illness, person with a pre-existing mental health disorder, person with the diagnosis of a mental illness, mental health disorder, behavioral health disorder, person who uses drugs instead of drug user or abuser, person with a substance abuse disorder, person with alcohol use disorder, person in recovery from substance use, alcohol disorder, person who has been incarcerated versus prisoner convict, excuse me. So all these charts, by the way, and there are even more examples that we didn't include, are in the PDF, which I will send you guys. Identity related terms. So these are, for example, a term to avoid, instead of the elderly, older adults, aging dependents, older population, older people. And the idea is avoid language that promotes stereotypes that other older adults. But please note that in certain cultures, right, the term elder is considered honorific. Geriatric instead of things like geriatric pregnancy, advanced maternal age, pregnancy at age 35 or older. The idea being using person first language to describe the age of a pregnant person. Older pregnant people may benefit from additional screening. This one was new to me, silver tsunami. And I never heard that before. But, I guess the suggestive alternative is, age-related population changes, age-related demographic changes, using affirmative language specific to demographic information. I've never used the phrase silver tsunami, but I do reference a lot, because I'm a neuropsychologist, for example, I do sort of reference a lot. I think for those of you who worked with me a little bit about kind of the origin of neuropsychology and some of the things that it's, a lot of the neuropsych work that started in literature and research early on, that as a challenge as a peds neuropsychologist, was focused on first people who suffered, maybe a traumatic brain injury or illness, but also on older adults, because fortunately people are living longer than they used to be. So while I haven't used the phrase silver tsunami, I'm fairly confident that at certain points I've used phrases like this, elderly people or the elderly. So this was humbling, to say the least, for me. I wanted to kind of also just see if there were any, some of the other examples in terms of person first or identity first that we didn't cover, for instance, instead of, the older term of prostitute, person who engages in sex work, person who takes medication or prescribed medication or assisted treatment, person taking prescribed medications, things like that. instead of smoker, even person who smokes. Um, Weight stigma, bias against individuals because of their body size. Sorry, I'm going down. So, like other forms of bias and discrimination, weight stigma, also called sizeism, anti-fat bias, leads to emotional suffering and psychological distress. Oop, I'm sorry, a couple chats. Let me go back. Um, Many barriers. I've heard MDs use geriatric pregnancy. Yes, yes. These were some notes I had for presentation I did on equitable language. Be consistent. Consider the person first language is used significantly more for children with disabilities, while identity first language is used to refer to typically development children, e.g. child with ASD versus neurotypical child. Disability scholars encourage using identity first language. Research has shown that identifying with a disability is associated with improved well-being and self-esteem, and it can be used to reclaim their disability and chronic condition. Yeah, I mean, if everyone wants to kind of read the rest of Yuna's chat, she's hit the nail on the head, and especially in some cases, for instance, as in the deaf community and autistic community, it's appropriate to use the preferred identity first language, such as deaf community or autistic community, because they do want to kind of reclaim that rather than and then until you kind of learn an individual person's preference. But yeah, okay. So back to kind of the weight stigma and bias, also known as sizeism, anti-fat bias, leads to emotional suffering, psychological distress. Sizeism stereotypes of individuals of higher weight may have a negative impact on their physical health and well-being. Health professionals who treat people disrespectfully or shame them to motivate changes in behavior create stress and may cause them to delay seeking healthcare or avoid interacting with providers. Intersectionality, which we covered before, may result in greater cumulative burden for people who experience sizeism, as well as other forms of oppression, and the stress that such oppression causes may damage people's health. So terms to avoid: ideal weight, goal weight, your preferred weight is, versus, so discussion of body weight in writing, your weight is, the health indicator for you to be aware of is our notes. We want to use neutral, non-judgmental language, and BMI is a population-based measure that is less helpful in individual clinical practice. And, as you guys have heard, I'm sure, in and of itself, BMI is there's a growing consensus, right, that BMI is a bit of a crude measure, because it fails to consider factors of, again, muscle mass, bone density, overall body composition, but also racial and sexual sex differences. So, this is it's there are the latest quote from kind of the American Medical Association issued guidance to physicians stating, BMI is an imperfect way to measure body fats in multiple groups, given that it does not account for differences across race, ethnic groups, sexes, genders, and age span. The American Medical Association also recognized the BMI's history of racist exclusion, as it is based primarily on data collected from previous generations of non-Hispanic white population. So BMI of itself is really problematic. And for my peers who work in eating disorders and in mindful eating, I have a very good friend whose whole mission is in that world. She's written a book about it, from a good friend from graduate school. And I would caution anyone who states the letters BMI in her presence. The study that informed the BMI was 84.5% white, 13.9% Japanese, 1.6% Black, and they were all men. Correct. Yep. So very problematic. So this kind of goes when I mentioned earlier about the problematic with some of the health terms and diagnoses that we have, that the data that we have used to create these terms or diagnoses or these conditions around it is problematic. Rather than focus on weight, focus exclusively on the health issue at hand: cholesterol, blood pressure, A1C levels. Terms to avoid. Also, this also goes for underweight people, lower weight, fat, obese. Obviously, we want to avoid these. Higher weight. To avoid perpetuating weight stigma, use neutral terms that affirm and respect the dignity of all individuals, regardless of their body fat size. But please note that the term fat is being reclaimed by individuals who identify as part of the fat acceptance community as a neutral descriptor to normalize the existence of fat bodies. I also thought about this from the perspective of culture, and those who may have English as a secondary language. So, for example, like I think about an example personally where, not to be TMI here, but I was at a threading salon with Indian women, and I was with a friend, and the woman who's threading, doing the threading, was older than me, perhaps around my parents' age. And she was kind of trying to relay to me that there was another woman who comes to the same salon and looks just like me, but you're fatter than her, or you're more fat than her, or something like that. My friend asked me after we left the place, oh my God, were you so upset? That's so rude. That's so this. And I said, God, no, I didn't even think about it. And she was like, really? And I said, well, I guess I took into account, and maybe it's as a child of immigrants, the factor. I said that I kind of said, if she were an Indian auntie, like a relative, if she wanted to comment on my weight in a negative way, I would have known that's what she was talking about. But I said, to me, that was just a transitional thing. She was using the language that she knew to basically say, you look like her, but different. And it was purely a descriptive thing. If I think about, if I speak some French, if I was going to be in France and I was trying to, in my, not fluent French speak, say to somebody, oh, it's bigger than this, I would maybe use the word gross, right? And that can be translated to fat. And I don't know, maybe somebody could take that the wrong way, but it's simply the word that I know to describe it being bigger. So I also just think about it from that perspective too, that in that moment, I didn't think about it at all as something being rude. It was just like a verbal descriptor for her too. So I also think about, where does language and culture play into this as well? Just something that popped into my head, and that's funny story. But it was interesting how my friends and I looked at it in two very different ways, given our different upbringings and backgrounds. So some language to be inclusive of body diversity to avoid microaggressions, unsolicited comments on body size or body changes, either observed or measured. So, obviously, try to avoid things like, wow, you're looking great. Look at how much weight you've lost. I'm so proud of you. You're getting so big. What happened? You've gained so much weight. Obviously, comments on body size or body changes warranted by the context, e.g. a medical discussion with a healthcare professional after asking consent. Is it all right if we talk about your weight? Would you feel okay if we discussed your weight? Or if in servant form, the next questions concern your weight, you may answer them or skip to the next section. How do you view or feel about your body? Do you have any concerns you might have about your weight? If yes, how would you feel about that? Avoid unsolicited commentary on body size or body changes, or do not comment at all unless you are the individual's healthcare provider. This prevents unintended consequences or mixed messages about people's health or impairments. And obviously, somebody who worked in a medical setting for many years and worked in cancer work, particularly for many years, this is something, I heard a lot from people that were maybe going through treatment that, maybe hadn't had more obvious signs of cancer treatment, like hair loss, that people like, oh, you've lost so much weight, and not fully understanding that. Identity related terms, disability. So in terms of, instead of things like, I'm sorry, I see someone put something in the chat. I like asking consent to speak about, for example, weight. Yes, agreed. Yeah. So instead of special needs, person with a disability, I know that I still find myself often saying special needs, and that's something that I need to work on. I certainly do. I'm sure I've said it to some people in this Zoom right now. Physically challenged, mentally challenged. This one, some of them I know are very old school, like mentally retarded, but I will certainly admit to the fact that I have used terms probably like physically challenged, right? Or special needs, certainly. I even, to be honest, and this is moving with the times, right? I mean, I remember once, someone said, "Oh, someone was referred to me, and there's actually a parent group out there," and she said, "Oh, well, I found you on the special needs mom group of whatever area of the city it was, of Gramercy." And so these are things that, even I have to remind myself to be mindful that we've moved to a different place with. Um, so, for example, instead, a suggestive alternative is person with a disability, person who has a disability, disabled person, child with a congenital disability, child with a birth impairment. Again, instead of mentally ill, person with a mental disorder, person with a mental illness. Again, using person first or identity first language as it is appropriate for the community or person being discussed. The language used should be selected with the understanding that the disabled people's expressed preferences regarding identification supersede matters of style. There are some patterns people with physical and intellectual disabilities often prefer person-first language, whereas the autistic community and people with sensory disabilities, e.g. blind people, often prefer identity-first language. Avoid terms that are condescending or patronizing. Deaf or hard of hearing. So instead of person with deafness, deaf person, person who is deaf. Most individuals who belong to the deaf or deaf blind cultures prefer to be called deaf or deaf blind, capitalized, rather than hearing impaired. This one I really had to be reminded about because I certainly have used the phrase hearing impaired a lot. The word deaf with a lowercase d is used to refer to audiological status, whereas deaf with an uppercase d refers to a particular group of deaf people who share a language. For example, American Sign Language and a culture. So again, just some examples here. Similarly with a blind person versus person with blindness, person with low vision versus visually challenged, visually impaired. I've certainly used these terms before, and I'm saying this out loud because I want to normalize it for anybody else. You guys, many of you are younger than me, so perhaps you're more up to date, but I can make these mistakes myself and have to work on undoing them. So for people who have complete or almost complete loss of sight may be referred to as blind. Other terms are acceptable for those with a vision-based disability. Some people may object to the term visually impaired because of the negative connotation of the word impaired. The use of such terms is complex and often culturally bound and deeply personal. If you're uncertain, again, how someone identifies, it's just recommended that you ask what identity first or person first terms they prefer. The IDEA classifications for IEPs include a lot of language surrounding impaired or impairment, like OHI, other health impairment. Exactly. Yes, this comes up a lot in education. It also comes up a lot in neuropsychology. Again, it bore out of an adult model after World War II, after people suffered injuries. And so the classifications, even in neuropsychology, once you were, more than one standard deviation below, like what was the norm, it was mildly impaired, moderately impaired, severely impaired. These are the terms that get used in neuropsychology a lot. And I know that while in children, I don't look at it that way. I'm looking more in it was a model that really bore out of being able measuring decline in people with dementias and with certain types of illnesses where you're unfortunately measuring decline more often than not. And so it's something in my text or in writing, I certainly avoided, especially using with children, especially with kids with neurodevelopmental conditions. But I would be lying if I said that I have not, said, visually impaired person, for example, out loud. And so I have to be mindful of these things in the language around them. Again, these were also some of more other terms around disability that also, made me stop and think. And I probably, said a lot of these. Fall on deaf ears, it says suggestive alternative, be willfully ignorant, deliberately ignore, tone deaf, and, an suggested alternative, insensitive, out of context. Midget, I think that's one hopefully people are more familiar with to not use, but instead little person, person of stature, having dwarfism, late instead of using that term, boring, mundane, so some of these phrases or old adages that get just said really unconsciously are we have to be more mindful about that. So even when, for example, everyone should have a voice in this matter, maybe everyone should have input. Again, the idea being that ableist terms and phrases are pervasive in everyday language. Although the use of these ableist terms may be unintentional, be thoughtful about how to avoid language that denigrates disabilities, right? So even stand up for instead of, you can use support or champion instead of turning a blind eye to, ignore, refuse to notice. Neurodivergent, obviously one that is close to my heart as a neuropsychologist. So what a person's neurology differs from the neurological majority. So these differences can include autism spectrum disorder, ADHD, dyslexia, apraxia. So frequently centered around diagnoses, fitting a narrow set of presentations and behaviors, but not solely dependent on the presence of a diagnosis. No universal agreement on the classification of neurodivergence currently exists, but somebody can be described as multiply neurodivergent when their neurocognitive functioning differs from dominant societal norms in multiple ways. For example, I'm an autistic person who may have dyslexia or epilepsy. But keeping in mind, neurotypical, being within the parameters of neurocognitive style that have not been either medically defined as disorders or culturally defined as neurodivergent. Again, it's important to remember there's no such thing as a normal brain. That's what I obviously hold true to. Human neurodiversity is a highly complex spectrum on which everyone sits. In terms of identity-related terms around race, ethnicity, culture, acculturation. This is the process by which groups or individuals adjust the social and cultural values, ideas, beliefs, and behavioral patterns of their culture of origin to those of a different culture. Acculturation for marginalized people is often traumatic, not simply a choice, but a matter of survival. Forced acculturation experiences are violent, intended to reinforce the primacy of a dominant culture and its people, for example, white, and perpetuating the societal racial hierarchy. Sorry, I'm just moving up. So for example, BIPOC, Black, Indigenous, and people of color. The term BIPOC is used to acknowledge that not all people of color face equal levels of injustice. And so it's considered many to indicate a hierarchy among communities of color. Therefore, use specific terms when referring to different racial and ethnic groups. When such a level of specificity is not possible, instead of maybe using BIPOC, use alternative terms such as people, persons of color, and communities of color. Racialized, race-based trauma. So a form of race-based stress referring to people of color and indigenous individuals' reactions to dangerous events and experiences of racial and discrimination. Such experiences may include threats of harm and injury, humiliating and shaming events, witnessing racial discrimination toward other people of color. Racial trauma is unique and that involves ongoing individual and collective injuries due to exposure and re-exposure to race-based stress. Hispanic, Latino, Latina, Latino, Latine, Latinat, Latin, Latinx, or Chicano. When writing about people who identify as one or more of these terms, you should consult with the individuals with whom you are working to determine the appropriate terminology. Kind of let you read through the slide, and we can share the slides, but and it's in the textbook, but you know, Hispanic is not an all-encompassing term. The term Latin and its related forms might be preferred by those originating from Latin America. Latin is gender-inclusive alternative that is more adaptable to the Spanish language than Latinx. But you know, some use the word Hispanic, for example, to refer to those who speak Spanish. However, not every group in Latin America speaks Spanish. So, for example, Brazilians speak Portuguese. And whereas Latino is gendered, Latino is masculine, Latina is feminine, whereas the term Latin is gender inclusive. Latinx may not broadly resonate as an exclusive term, given that X signifier doesn't conform with Spanish or Portuguese syntax, which was something I was not fully aware of. Indigenous peoples around the world. When writing about Indigenous people, use the names that they call themselves. In general, refer to an Indigenous group as a people or nation rather than as a tribe. Identity. And I just also want to say that, like, before I move on to this next section, that there's more examples around a lot of the terms around race, ethnicity, and culture in the inclusive language guide. And again, so I encourage you guys to, peruse through that. And if there's things that you want to know a little bit more about, and they cover not only just some of these specific terms specific to certain cultures, but also more general terms such as enculturation, ethnic bias, um, the colorblind policies, um, uh, and like anti-racism, things like that. Um, so gender identity and sexual orientation. So again, terms to kind of avoid birth sex, natal sex, suggested alternative, sex assigned at birth, assigned sex. Born a girl, born female, again, assigned female at birth, assigned male at birth. Female to male, assigned female at birth, assigned male at birth. I think also you guys might have had a talk around this recently with was it Jamie who led that talk? So um, other terms to avoid: hermaphrodite, she-male, he, female, tranny, transvestite, transsexual, intersex, LGBTQ, LGBTQ plus, transgender person, transgender people, gender queer, queer. Some people may use terms to describe themselves, and others may be perceived as pejorative, but are empowering for those individuals and their communities. So, for example, tranny or queer are examples of such terms. Some members of the LGBTQ plus community have reclaimed them, whereas others may consider them offensive. I think this then also goes back to asking people what is preferred, right? Instead of transgender is a dated term that suggests a point in a time when a person became transgender versus which diverged from the lived experiences of most transgender people. Socioeconomic status, poor, poor people, instead saying people whose incomes are below the federal poverty threshold, people of low SES, low socioeconomic status, people without housing, instead of blue collar worker, skilled trades worker, manual labor, white collar worker, instead say salaried professional. As always, there should be room for nuance and flexibility when using these terms. Many people find the terms low class and poor pejorative. Conversely, class solidarity exists in poor people's movements, and many individuals proudly identify as working class. Despite specific income brackets, define specific income brackets and levels if possible, e.g. low income. And these terms at the bottom are considered, like blue collar and white collar, are considered outdated as they originated in the early 20th century. I fear I'm running out of time, so I'm going to move through this quick. I apologize, guys. Microaggressions in conversations: culturally appropriative and pejorative language, violent language, language that doesn't say what we mean. So these include culturally appropriative and pejorative language. So for example, the term cabal is considered anti-Semitic. Jews have long been accused of being part of a secret group that controls the economic and political world order. It originated from the word Kabbalah. Today is often denoted as Jewish cabal on social media and a dog whistle for Jewish control. Powwow is an example. And a celebration, powwow is a celebration and display of indigenous food, music, dance, and traditional clothing. It's incorrect to use powwow to refer to a quick impromptu meeting because real powwows are carefully planned in events. So instead of using powwow, try to use huddle or quick meeting. Totem pole, phrases like low man on the totem pole, perpetuate stereotypes, imply kind of a monolithic culture. They also misinterpret totem poles because totem poles are not designed to reflect social ranking. In fact, some cases, the figure at the bottom of the totem pole is the most important. Violent language, things like saying killing it, nailing it, and suggest alternative, great job, awesome. Instead of take a shot at, give it a go. Target population, instead say specific population. Instead of something like off the reservation, you disagree with the group. Although these terms and idioms may seem innocuous ways to signal achievement, it's notable how pervasive violent or militaristic language is seen as positive when it should be the opposite. Even when used in medicine, violent metaphors have been described as ironic, unfortunate, necessary. Language that doesn't say what we mean. So instead of saying committed suicide, suicide, died by suicide, death by suicide, survived a suicide attempt. Commit implies a crime or sin. Do not describe suicide attempts as successful or unsuccessful or failed. Instead, say survived a suicide attempt, similar to describing someone who has survived a medical attempt, such as a cancer or a heart attack. And again, this goes down to child prostitute or date rape, instead saying a child who has been trafficked, child who has been raped, rape or sexual assault. The term date rape may lead to confusion that date rape is somehow different or less serious than rape. It's better to name the crime followed by the information about the perpetrator of that crime. Okay, so this is the thing. I'm sorry to rush through that at the end, but I see we're running out of time. I'm going to really quickly post this because I did, sorry, have this PDF. I'm going to post it in the chat so you guys have it. I don't know if anyone else has any additional comments or thoughts that they want to share. I'm putting this in the chat. But this is the full PDF. There are a lot of examples. I know for me, it was a good reminder about some of the language that I use and also some of what I thought was seemingly benign language. And just being mindful about the words that I use. I think oftentimes I'm much more mindful in my writing. No problem, Emily. And in person, you know, I think we all get a little tongue-tied. And as somebody who's a bit older, I find that I rely on things that I've learned that were incorrect previously. And so certainly an active learning process. And the best that I can say that I do in the moment is apologize when I've made a mistake and encourage being corrected. And bye, Samantha, no problem. And so, you know, that's at least what I do. And I just admit my mistakes.